Thank you for nice introduction to Chairman. As we know, the standard prophylaxis regimen in the HBV and the nucleoside combination after transplantation. Why? Now it's the nucleoside and tide monotherapy. The reason is the first, the inconvenience of the patient in long-term follow-up period. The second, in the economically high cost in the HBV regimens. Today's I talk the 3 points. One, in the nucleoside and nucleotide analog is enough to prevent HBV recurrence. I show you the short-term results and the long-term clinical experience. The other is who is the best candidate to nucleoside analog monotherapy. The third, in what is the optimal timing of the monotherapy. For example, the immediate post-op period was second option in the first combination and the sequence of the nucleoside monotherapy. I first summarize the sequential monotherapy. At first, HBV and the nucleoside, and the second moved to the nucleoside monotherapy. In this slide, I showed the retrospective cohort study of the sequential therapy. This study includes 47 patients. Among them, DNA positivity in the 4.5%. The combination at least 12 months. In this, the blue box showed the before HBV continuation, the various combination HBV lamivudine, HBV lamivudine adefovir, and HBV entecavir. After HBV discontinuation, the various kind of nucleoside analog, the choice, the entecavir, tenofovir, or the other combination, according to the previous nucleoside analog used. The final outcome after follow-up 2 years, only 3 patients showed S-antigen positive status. However, the DNA was still negative and the liver enzyme still normal range. The other study, in also retrospective study, included 61 patients. In this study, HBV combination used at least 12 months. The risk factor in the DNA positivity in the 21% and the DNA median titer in the 7 lows. This blue box shows the nucleoside analog before HBV discontinuation. Mostly HBV plus lamivudine, 1 patient HBV entecavir. After discontinuation, the various kind of the combination, lamivudine adefovir, lamivudine tenofovir, entecavir adefovir. After follow-up the 15 months, the 2 patients showed HBV S-antigen positive status. The recurrence time in the 3 months and the 16 months after HBV withdrawal. Also in this study, HBV DNA is still negative and the liver enzyme normal range. This study showed the prospective study, including the 17 patients. HBV combination used at least 6 months. Risk factor in the DNA positivity in the 88% and the median DNA titer in the 7 lows. Before HBV discontinuation, the HBV lamivudine, HBV lamivudine adefovir, and HBV tenofovir. However, all patients used tenofovir and the emtricitabine combination, HBV withdrawal. So for the follow-up period of the 2 years, the 2 patients showed HBV S-antigen positive status, but HBV DNA is still negative and liver enzyme is still normal range. This study, the first randomized controlled study, used HBV plus tenofovir versus tenofovir only drug after liver transplantation. In this study, there is a time of the liver transplantation to HBV withdrawal of 3.4 years. All patients HBV and the tenofovir combination treated about 6 months. And then 2 groups divided. 1 group in the randomized tenofovir and the HBV group, the other group tenofovir only group. As you can see here, follow-up period 72 weeks. The result is no HBV S-antigen positive and HBV DNA negative and the liver enzyme normal range. last year, the Korean multi-center center reported the post-transplantation sequential anti-HBV monotherapy after 1 year combination therapy. This study included 29 patients. As you can see here, after liver transplant period, immediately 1 year HBV and anti-HBV combination, and then the withdrawal of HBV and the continued anti-HBV therapy. In this group, the risk factor DNA positivity was 52%. Final outcome at 2 years, only one patient showed HBV S-antigen positive status. This one patient, HBV recurrence, developed after hepatocellular carcinoma recurrence. Interestingly, in this study, the liver biopsy at the 1 year and the 2 year time. As you can see here, although the liver enzyme is still normal range, however, some patients show the liver in the portal inflammation and the ductal reaction. However, there was no HBV S-antigen staining, the immunohistochemical study in liver tissue. I briefly summarize the initial monotherapy nucleoside analog. This study in the important paper the last 3 years ago. This study in the prospective study and including the 80 patients. The risk factor in the median DNA 3 log and the DNA positivity 74%, DNA E-antigen positivity 27%. Median follow-up period of 12.6 months. Among them, nucleoside analog was used in the 59% before transplantation. This blue box shows the type of nucleoside analog treatment before transplantation. Lamivudine and lamivudine-adefovir, entecavir, and entecavir only. However, after transplantation, all patients used entecavir. There is the final result. The recurrence rate of S-antigen was 22%. 8 patients showed persistent HBV S-antigen positive after transplantation. In contrast, 10 patients showed the reappearance of after initial loss of HBV S-antigen. But however, the 17 of 18 patients showed HBV DNA negative and still liver enzyme normal range. This graph showed the cumulative rate of HBV S-antigen clearance in monotherapy 1 year 86% and 2 year 91%. In bottom graph show the clinical factor associated with HBV S-antigen clearance. As you can see here, transplant time, the viral load is very important. The second in the donor anti-HBV S antibody positivity is the important factor. In this study, show the change of S-antigen titer in 17 patients. As you can see here, most patients in the DNA S-antigen titer in the moderate and high, but after transplantation, mostly low titer. At this time, in this patient, what is the meaning of the low HBV S-antigen titer? Recently, the two opinions in the possible. One in the HBV S-antigen production maybe come from pathway independent of HBV DNA replication by the nucleoside analog. So, low titer is still important. The other opinion in the serum HBV DNA is still negative. It is not important. With high genetic barrier drugs such as entecavir and tenofovir. Last year, another prospective study, prospective monotherapy. In this study, in the 89 patients, all patients were given antiviral drug before transplantation. At this time, the transplant time they decided, patients over 2,000 international unit DNA, they selected the HBV and the nucleoside combination. However, less than 2,000 international unit HBV DNA, at this time they selected nucleoside analog only. The risk factor in the 20% in the DNA positivity. The final analysis in the 75 patient, the nucleoside analog only group. In this blue box, show the before and after transplantation nucleoside drug. The namibin adenophobia, entecavir, and tenofovir, and the entecavir tenofovir. The definition of the HBV recurrence in the S antigen or HBV DNA reappearance. After follow-up 21 months, 6 of 75 patients showed HBV S antigen positive and the DNA positive. The recurrence in the 8%. Interesting point among them, 5 patients recurrence associated for the patient compliance. In this study, the HBV S antigen clearance rate without HBV, 2-year clearance rate is 92%. Another interesting point in the anti-HBV antibody appearance in this group in the 29%. The reason of the antibody appearance without HBV may be associated with booster vaccination before transplantation, and the second in the donor was mostly family members. So, in this study, the background of the good outcome may be associated with good viral suppression before transplantation. Maybe LDLT in the more comfortable compared to the cadaveric liver transplantation. The other important point in the nucleoside monotherapy, both the important point in the drug compliance, the very important compared to the combination the prophylaxis. At this time, the most study in the follow period very relatively the 2 year and very long time, short time. However, the last year long-term follow-up study of the nucleoside monotherapy. In this study included 362 patients, risk factor in the E antigen positivity 30%, median DNA titer in the 3 logs, median follow-up in the about 53 months. All patients treated with nucleoside analog drug before transplantation and after transplantation. Very kind of combination used in this study. This study showed the dramatic result. And 8 years the DNA HBV antigen negative rate in the 88% and the undetectable DNA in the 98%. In this study, what is the virologic relapse according to the nucleoside analog regimen? Totally 42 patients virologic relapse at this time. Among them, 36 patients had YMDD mutation. In this graph, the lamivudine and the other combination group relatively high virologic relapse compared to the entecavir therapy. Now, the previous study, what is the risk factor of virologic rebound after 8-year nucleoside monotherapy? First in the lamivudine, maybe drug resistant. The other in the hepatocellular carcinoma. It is recurrence closely related to HBV recurrence. The other in the HBV DNA viral load at the transplantation time. Recently, the systemic review showed the HBV recurrence rate type of anti-HBV prophylaxis. As we can see here, the high genetic barrier and the HBV combination very good. However, the relatively high cost. But the HBV and the lamivudine combination compared to the high genetic barrier monotherapy after withdrawal of the HBV and the 3.9 recurrence rate relatively good. However, we needed the long-term follow-up time. I briefly summarize my talk. I would like to suggest the good candidate of nucleoside analog monotherapy. Maybe the previous no lamivudine history is closely related to the YMDD mutation. The other in the HBV DNA titer negative or low at the transplant time. Another in the no hepatocellular carcinoma patient. The other, the good point in the anti-HBV S positive in donor aspect. The second, I suggest what is the optimal timing for the nucleoside monotherapy. For example, HBV DNA over 3 log at the transplant time, I prefer the combination therapy, sequential to the monotherapy. Any drug resistant for the antiviral drug, post-recombination and monotherapy. HBV DNA negative and the no nucleoside history, I prefer the post-monotherapy. Which drug is the better? Maybe tenofovir and entecavir, for example, the high genetic barrier is better, but the high viral load at the transplant time, I prefer the tenofovir compared to the entecavir. Thank you for your attention.